Hello and welcome to Health Assessment. So today we're going to be talking about just an introduction to health assessment. So our agenda is the nurse's role here, the health history and interview, and then technique, safety, and infection. Our student learning objectives here for this lecture today. So when we talk about health assessment, we're not just talking about performing a head to toe exam. Health assessment is a deliberate, systematic process of collecting both subjective and objective data to form clinical judgment. So first, let's break that down. Subjective data is what the patient reports, and this includes symptoms, feelings, perceptions, and concerns. It can't be observed directly by the nurse. For example, saying something like, I feel short of breath, or my pain is a 7 out of 10. This is subjective information versus objective data. This is what we as the nurses are observing, we're measuring and verifying through our physical examination techniques. This can include vital signs, inspection findings, lab values, auscultated lung sounds. Your Text by Sharon Jensen emphasizes that assessment is not passive data collection, it's active analytical thinking. And as nurses, we are constantly noticing cues, interpreting their meaning, and determining their significance. So health assessment forms the foundation for clinical judgment. It guides diagnostic reasoning. It drives every other step of the nursing process. And if our assessment is incomplete or inaccurate, every step that follows, diagnosis, planning, implementation can be flawed. So another major point from Jensen is that assessment is ongoing and dynamic. It doesn't just occur at admission. Every time you enter the patient's room, you're informally assessing their skin color, their level of consciousness, respiratory effort, their emotional state. As a nurse, you will be constantly collecting data. So finally, health assessment helps us identify actual problems, any potential risks, health promotion needs, and assessment is how we determine priorities. It helps us answer the question, what matters most right now for this patient? And in Jensen's clinical judgment approach, assessment is where noticing begins. And without noticing accurate cues, sound clinical judgment cannot occur. So when we say health assessment is foundational, we truly mean it is the intellectual and clinical starting point of professional nursing care. The slide illustrates the 3 levels of prevention: primary, secondary, and tertiary. Jensen emphasizes that professional nursing assessment is not only about identifying illness, it's about preventing illness and promoting health. So let's walk through each level. We have primary prevention, which focuses on preventing disease before it occurs, and this includes health promotion, lifestyle counseling, vaccinations, education about nutrition, exercise, smoking cessation. At this level, the patient may not be sick at all, but our role is proactive. For example, we'll be teaching about blood pressure control before hypertension develops, or even encouraging safe sex practices, promoting childhood immunizations. Health assessment here identifies risk factors before disease manifests. And this aligns with your book's emphasis on early cue recognition. We identify vulnerability before pathology occurs. Then we have secondary prevention, which focuses on early detection and early treatment. This includes screening tests, routine physical exams, blood pressure checks, mammograms, colonoscopies. And at this stage, disease may already be developing, but is often still asymptomatic or in those early stages. And assessment here plays a critical role because we're looking for subtle cues, such as slightly elevated blood glucose or abnormal screening findings, mild symptoms patients may dismiss. Early identification here can improve outcomes significantly. And then finally, we have tertiary prevention, which focuses on managing existing disease and preventing complications. So this would include rehabilitation services, chronic disease management, education on medication adherence, preventing any exacerbations, and slowing disease progression. So an example would be educating a heart failure patient about daily weights, or supporting a COPD patient to avoid any flare-ups. And assessment at this level is ongoing and dynamic. We're monitoring their stability, treatment effectiveness, complication risk, and their functional status. So assessment here is really central at all three levels, whether we're preventing disease, detecting it early, managing chronic illness. We rely on accurate assessment and clinical judgment. There are different types of health assessments, and understanding when to use each one is really part of developing our clinical judgment. So let's walk through each framework. We have comprehensive or head-to-toe assessment. This is the most detailed and complete type of assessment. It's typically done upon admission, during an initial patient encounter, in outpatient wellness exams. So you're collecting a full health history and systematically examining every body system. You think of this as building the patient's baseline. Without a baseline, you cannot recognize change, and so this type of assessment is really thorough and systematic, and it prevents any missed findings. Then we have focused or problem-oriented assessment. A focused assessment zeroes in on specific complaint or condition. For example, a patient may report shortness of breath, and you may focus on respiratory and cardiovascular systems. Or a patient has abdominal pain, you're maybe concentrating on the GI system. So this is kind of like a narrowing of your lens where it's guided by patient's symptoms, clinical priorities, and your initial findings. Focused assessments require strong clinical reasoning, and you must determine what is going to be relevant for your patient. Emergency assessment, this is a rapid priority based. The goal is really immediate stabilization. Here you're assessing airway, breathing, circulation, level of consciousness, any life-threatening conditions. This isn't a systemic head to toe. It's really priority driven. You're going to assess what is going to kill your patient first. And then we have ongoing shift assessment. This is done repeatedly throughout care. It answers, has the patient improved? Has anything changed? Are my interventions working? Are there new problems developing? This type of assessment is dynamic. You're constantly comparing current findings, previous findings, their baseline, and you're detecting any changes here. When we talk about a systematic framework approach, we're talking about how we organize our thinking during assessment. Assessment isn't random. Professional nursing assessment is structured and it's intentional. So let's walk through each organizing framework. We have a body systems approach. This is the most common framework students learn first. You're going to assess the patient's system by system. So like cardiovascular, then respiratory, GI, neurological, musculoskeletal, etc. This approach promotes completeness, it reduces missed findings, it helps with documentation, and it's especially helpful for beginners because it provides structure. Functional health patterns. This framework looks beyond body system and it really focuses on how the patient functions in their daily life. Some examples might include nutrition and metabolism, activity and exercise, sleep and rest, coping and stress tolerance, role and relationship patterns, and this allows us to look at the patient more holistically, not just their organ systems, but their lived experience. And it's especially useful in outpatient, community, and chronic care settings. Developmental considerations. Assessment must be tailored to the patient's developmental stage. For example, a pediatric assessment differs from an adult assessment. An older adult may have sensory or cognitive changes that affect their communication, and normal findings vary by age. So professional assessment is going to require adjusting expectations based on their development. Lastly, safety first mindset. So regardless of framework, safety always is going to come first. Even during a systematic head-to-toe assessment, you must be asking, is the airway stable? Is breathing adequate? Is circulation sufficient? Is this patient at risk right now? And if you discover something urgent, you're going to pause the framework and address the safety issue first. So structure is going to guide you, but safety overrides the structure when necessary. So the nurse's role in health assessment. So it is the first step of the nursing process and everything else builds on it. If we think about the nursing process, assessment, diagnosis, planning, implementation, evaluation, assessment drives all of it. And if your assessment is incomplete or inaccurate, your nursing diagnosis may be wrong, your plan may be ineffective, and patient outcomes can suffer. So nurses gather, analyze, and synthesize data. We don't just collect information, we interpret it. We gather subjective data from the patient, objective data from our physical exam and diagnostics, but then we go deeper and we analyze it. So what is normal? What's abnormal? What's urgent? What fits together? And we synthesize it. Do these findings suggest a pattern? Is it consistent with the patient's condition? Is this a new change? This is where clinical judgment develops. So assessment is intellectual work, not just a checklist. Our role in promoting health, preventing illness, and advocating. So our role really extends beyond identifying disease. We promote health through our education on lifestyle, preventative care, encouraging screenings, and we prevent illness by identifying risk factors early, recognizing any subtle changes, and acting before complications develop. We also advocate when findings don't align, or when our patient's condition changes, when safety is at risk, or when a patient's voice isn't being heard by other people in their care. Assessment gives us the evidence we really need to advocate effectively. So, if I haven't driven it home yet through our 8th slide, assessment is really important. So this slide shows the 5 steps of the nursing process, and you'll often hear the acronym ADPI. So assessment, diagnosis, planning, implementation, evaluation, ADPI. And these steps are sequential, but they're also cyclical. So assessment begins the process, but it doesn't end there. We reassess continuously. I am literally tripping on my words. I'll get it back. Hold on. So assessment is the foundation, where I just talked about how we collect subjective data and objective data. But again, it's not just collecting information, it's thinking about it. We're noticing cues and identifying patterns. And without that strong assessment, everything that follows could be flawed. And then we have diagnosis, and this is the nurse's clinical judgment about the patient's response to health conditions. This is an important distinction. Medical diagnosis identifies disease, and nursing diagnosis identifies patient responses. For example, they might have a medical diagnosis of pneumonia. A nursing diagnosis we might, implement is impaired gas exchange. So the diagnosis helps us prioritize both the medical and the nursing diagnosis. In planning, so we set measurable goals, identify expected outcomes, determine appropriate interventions. So this is where planning is going to be individualized for your patient, and it really should reflect the patient's values, their current conditions, and any available resources. Then we have implementation. This is where we carry out interventions. For example, we might be administering medications or providing oxygen, teaching the patient something, or repositioning, monitoring. But even during implementation, assessment is going to continue. We're watching for a response in real time. And then lastly, we have evaluation, which answers one essential question: did our intervention work? If the patient improves, we're going to continue or advance the plan. If the patient does not improve, we're going to reassess and modify. And that brings us back to assessment. So the process is circular, it's not linear. Clinical judgment is the thinking process that is going to underlie safe nursing practice. It's not just about performing skills here, it's about recognizing what matters and deciding what to do next. Clinical judgment involves 4 key steps: noticing, interpreting, responding, and reflecting. So noticing begins at assessment. You're identifying cues, any changes in their vital signs, abnormal physical findings, patient statements that they might be, talking to you about, any subtle behavioral shifts. Strong noticing skills really require patient, presence and attention to detail. You're always comparing back to their baseline. Interpreting means asking, what do these findings mean? You're going to cluster cues together and look for patterns. And instead of viewing findings individually, you're going to connect them. For example, maybe they have an elevated temperature. We're going to connect that to increased white blood cell count and maybe some wound drainage. This may indicate infection, right? So we're interpreting, collecting data to clinically reason. And then responding, you're acting on your interpretation. This might include reassessing or implementing an intervention. Maybe we have to escalate care and notify the provider. Your response should match the priority and urgency of the situation. And lastly, reflecting. Reflecting happens during and after care. You consider, did I recognize the most important cues? Did my intervention work? What could I improve next time? As nurses, we're always reflecting because reflection strengthens future clinical judgment. Critical thinking. This is what turns assessment into meaningful clinical judgment. And it's not enough to just collect data. Again, you must think about that data. So you're going to want to differentiate relevant versus irrelevant data, because not every piece of information carries the same weight. For example, a patient admitted with chest pain reports a mild headache. So which is more relevant right now? Critical thinking requires you asking yourself, what relates directly to the current problem? What impacts safety? What requires my immediate attention? Prioritization is really going to begin here. Recognizing patterns. So instead of viewing findings separately, we're going to connect them. Again, like an example, tachycardia, hypotension, cool, clammy skin, altered mental status. When clustered together, these cues may indicate shock. So a pattern recognition is a skill that strengthens with experience and time, but you're going to get there. We're going to get you there. Then, like I said, we always want to compare our findings to baseline because change is often more important than the value itself. Like a blood pressure of 100/60, it may be normal for one patient, but dangerous for another. So critical thinking really requires us asking, is this new? Is this worsening? Is this consistent with their baseline? Trend recognition is key in ongoing assessment. And then identifying red flags early. So red flags are subtle early warning signs. Examples would include new confusion or decreased urine output, increasing work of breath, or a slight drop in oxygen saturation. So the earlier we recognize deterioration of our patient, the better the outcome. Now we're going to go into a little bit about therapeutic communication skills. So therapeutic communication is one of the most powerful tools nurses use during assessment. How we ask questions directly impacts the quality of data we collect. It also impacts our patient's trust, comfort, and honesty. So let's break down these principles. We have open-ended questions, which help us to invite the patient to explain in their own words. So instead of, does your chest hurt, which is a yes or no question, ask, can you describe what you're feeling? That's more open-ended, and it encourages them to elaborate more about that and reveal any unexpected information. It prevents yes or no limitations. These are especially useful at the beginning of an interview. Active listening. Active listening means being fully present. This includes maintaining eye contact, nodding, avoiding any distraction, not formulating your next question while the patient is still speaking. Because patients often reveal critical information after a pause if we allow for silence. Silence is therapeutic when used intentionally. Reflection. Reflection involves restating or paraphrasing what the patient says. For example, the patient might say, I'm scared about what might happen. The nurse might reflect and say, you're feeling anxious about the future. So reflection is really validating the patient's feelings and encouraging them to share, maybe more deeply. Clarification. Clarification ensures accuracy. So, for example, when you say dizzy, can you describe what that feels like? Clarification is something that is going to prevent any assumptions. Remember that dizziness can mean different things. It can mean vertigo, weakness, lightheadedness, or imbalance. So precision is really going to matter here in our assessment. Empathy. Empathy is acknowledging the patient's experience. For example, they might say something and you might say, that sounds really difficult. Empathy doesn't mean agreeing, it means recognizing emotion. Patients are more likely to disclose accurate information when they feel understood. Avoid leading questions. Leading questions suggests an answer. So, for example, you're not having chest pain right now, right? This can influence responses and reduce accuracy. Avoiding any false reassurance, like saying statements like everything will be fine, because we can't guarantee outcomes, and false reassurance can reduce trust. Instead, we can say something like, we'll continue monitoring you closely and keep you informed. Avoid any interrupting, because no one likes to be interrupted. But interrupting limits important information. Patients often reveal their main concern within the first minute, so try not to interrupt them when they're talking. This slide moves from principles to really specific techniques that you can actually use in patient interactions, and these are tools you will probably use every single day in nursing practice. So like we talked about, active listening, facilitation. So this encourages the patients to continue. Simple statements like go on or and then and These kind of prompt the patient to keep talking and signal that you're interested in learning more, allows for more complete storytelling, and this often leads to more important assessment information. Interpretation, this is going to reflect your perception of the patient's feelings, like you seem happy about that or you sound frustrated. This invites confirmation or correction, and it helps deepen emotional understanding. Encouraging them to elaborate, so like tell me more about that. This invites more detail and it prevents assumptions, and it often uncovers key data. Empathy, we talked about. Confrontation. So in nursing communication, confrontation is gentle and supportive. It's not aggressive. Saying something like, you seem upset, or this can draw attention to inconsistencies or unspoken emotions, and it can help patients process their feelings. Support, saying something like, I understand, or this reassures the patient that they're not alone. But we must be careful because support should not replace empathy or minimize feelings. Summarizing. So this is what I'm hearing you say, for example. Summarizing is going to confirm accuracy, and it prevents any misunderstanding, organizes information. So assessment does not happen in a perfect controlled environment unless you're taking the NCLEX. So patients come with unique circumstances that can affect communication, data collection, and interpretation. And as nurses, we're going to have to adapt our approach while maintaining professionalism and safety. So let's walk through some of these examples, like hearing impairment. So with hearing impairment, you want to face the patient directly. Speak clearly, you don't have to speak loudly. Ensure that hearing aids are in place and they're functioning. If they have them, reduce any background noise, so maybe shut the door or pull the curtain. Use written communication if needed. You don't want to shout at the patient, it can distort their sound, and clarity is more important than volume. So always confirm understanding. Language barriers. When there's a language barrier, you're going to want to use certified medical interpreters. Avoid using family members, especially children. Speak directly to the patient, not the interpreter. Use short, simple phrases. Assessment accuracy really depends on clear understanding, and miscommunication can lead to serious clinical errors. Cognitive impairment. So with cognitive impairment, you want to ask simple, direct questions. You want to allow for extra time for responses and verify information with caregivers if appropriate. You want to assess their baseline mental status and be careful not to assume confusion is chronic. It could indicate acute changes. Emotional distress. Patients experiencing fear, grief, anxiety, or anger may struggle to provide organized information, and in these cases you just want to kind of slow down, use empathetic statements, allow for pausing, prioritize psychological safety, and sometimes emotional stabilization must happen before a full assessment. Trauma-informed care. Trauma-informed care recognizes that many patients have experienced past trauma, so approaches include asking permission before touching, which should always be the case, explaining each step of the assessment, respecting boundaries, avoiding sudden movements. So the goal here is to prevent re-traumatization. Safety and control should be emphasized. Pediatric versus older adult patients. So like I said in the beginning, assessment really must match developmental stage. And with pediatric patients, which you'll find when you take peds, is that you have to use simple language, engage with the caregivers, and be aware of developmental norms. With older adults, you want to consider sensory deficits and allow more time, and differentiate normal aging from pathology. So a normal finding in one age group may not be normal in another. Communication is more than the words that we say, right? So patients often respond more strongly to how we say something more than what we actually say. So both verbal and nonverbal communication directly impact assessment accuracy. Tone. So tone communicates emotion and intent. So a calm, steady tone is going to promote safety and trust. If you're having a rushed or irritated tone, it may make the patient withhold information, feel dismissed, feel anxious. Even a neutral question can feel threatening if delivered with the wrong tone. So professional presence is going to matter. Our body language, including posture, facial expressions, and positioning. For example, if you're standing over a patient, it may feel intimidating. Crossing your arms may appear closed off. Glancing at the computer repeatedly can signal distraction. So you want to have like an open posture, leaning slightly forward like you're interested, sitting at eye level. This is going to convey attentiveness and respect. And patients often read body language before they even process words. Eye contact. Appropriate eye contact signals engagement and interest. And this should also be considered culturatively because in different cultures, eye contact is seen as disrespectful. So too much eye contact may feel aggressive in some cultures, while too little may feel dismissive. So balance is really key here. Silence, we talked about, this is an intentional therapeutic tool. When we resist the urge to fill silence, so patients often continue speaking, emotion may surface, important information may emerge. So silence can feel uncomfortable for us, but it may be a really powerful tool for the patient. Cultural awareness, because culture shapes communication. Consider differences in personal space, like I talked about just now, eye contact, touch, emotional expression, decision-making roles. Assessment should be culturally sensitive, and we should avoid assumptions and ask respectful, clarifying questions when needed. Supportive techniques, these are especially important when patients are experiencing barriers to communication or emotional vulnerability. These techniques create psychological safety and improve the accuracy of assessment data. So we talked about using interpreter services appropriately. If we have a patient that speaks limited English, you always want to use those certified medical interpreters, which should be available to you. Speaking slowly and clearly, we talked about using pauses between ideas, validating emotions, like saying things like, I can see why that would be frustrating for you. It's building trust, reducing defensiveness, reducing environmental distractions. Environmental factors affect communication quality, so if possible, you're going to want to turn off the television, silence any alarms when safe, close the door or curtain, and minimize any interruption, because even small distractions can disrupt the patient's focus and disclosure. So a chaotic environment really limits the effectiveness of our assessment. Using the teach back method. So teach back ensures understanding. An example would be, just so I know I explained that clearly, can you tell me in your own words what we discussed? And they would go ahead and do that, and you can assess their understanding and comprehension, or identify any misunderstandings and support that and strengthen your patient education. These are barriers to accurate data assessment. Wow. Okay. Assessment is only as accurate as the information we receive, right? So there's multiple barriers that can interfere with our data collection. And as nurses, we must recognize these barriers and adjust our approach accordingly. So cultural differences. Symptoms might be described differently in different cultures, or willingness to disclose information, or their beliefs about illness. We talked about eye contact and communication style. Some cultures might minimize pain. Others may express pain more openly. We want to avoid any assumptions, and we want to ask open, respectful questions. Health literacy. Health literacy is a patient's ability to understand health information. Patients may nod in agreement, they say they understand, but not truly comprehend what's being discussed. And this can lead to incomplete history and misunderstanding of treatment plans. So you want to use simple language. The teach back method, it can really help overcome this barrier. We talked about developmental stages, children versus older adults, or even adolescents. Cognitive ability. Cognitive impairment really impacts reliability of self-reported data. So that may include dementia or delirium, or even just having an intellectual disability. So when needed, we'll corroborate history with family or caregivers, maybe even past providers. Pain, fatigue. Definitely a barrier to accurate data assessment. Patients in pain or exhaustion, they might just provide short answers or appear disengaged or have difficulty concentrating. So sometimes symptom stabilization must occur before we can go ahead and do a thorough assessment. Anxiety. Anxiety affects processing and recall. Highly anxious patients may speak rapidly, provide disorganized information, focus on the worst case scenarios. Situations. Us utilizing calming techniques, it might improve the quality of our interview here. And like I said, environmental noise, you want to kind of reduce that whenever possible to help with concentration, emotional safety, and data accuracy. This slide focuses on something that we can quietly interfere with accurate assessment. Our own thinking. So we all have bias and assumptions, which we know can distort clinical judgment, and it often happens without us realizing it. So as professional nurses, we really must practice self-awareness alongside our assessment skills. You want to avoid any premature conclusions, and these can happen when we decide too quickly what the problem is. So, for example, like a young patient reports chest pain. We might just assume that that's anxiety, or an older patient reports fatigue. We might just assume, oh, they're just aging. When we close the diagnostic process too early, we risk missing serious conditions. So assessment is going to require us to be curious. Instead of deciding quickly, we should ask, what else could this be? Avoid stereotyping. Stereotyping involves making assumptions based on age, culture, weight, socioeconomic status, gender, or diagnosis. So assuming a patient with a history of substance use is drug seeking, or assuming older adults are confused, a young person is healthy. Stereotypes can really interfere with the objectivity and compromise equity in care. Every patient deserves an individualized assessment. You want to maintain objectivity, so this means documenting and interpreting what you observe, not what you think it means emotionally. For example, instead of writing patient was dramatic about pain, you want to document patient reports pain 8 out of 10, guarding noted. You want to separate your personal reaction from the observable data. Clarify any inconsistencies. If something doesn't align, ask some follow-up questions, reassess, seek clarification. The comprehensive health history, this is a structured conversation that allows us to gather thorough, organized data. So this is not just small talk. When you're getting a comprehensive health history, it's a systematic collection of information that guides our diagnosis and care planning. So let's walk through each component. We have the chief complaint. So this is the patient's primary reason for seeking care. It should always be brief, in the patient's own words, placed in quotation marks. We're not going to interpret it. We're going to document it exactly as stated. The chief complaint guides the rest of the interview and physical exam. So let's look at a couple of these examples. Something like, I have burning pain in my chest. This immediately triggers multiple possibilities. It might be a cardiac cause. It could be acid reflux, musculoskeletal pain. At this point, we're not deciding what it is. We're going to move into old carts to clarify. We're going to move on to the next part of our comprehensive assessment. History of present illness. This is where your clinical reasoning really starts. This is more than asking what's wrong. It's asking the right sequence of questions to uncover patterns. So describe the current concern in a structured, systematic way, which will include old carts, which is onset, location, duration, character, aggravating factors, relieving factors, timing, severity, and associated symptoms. There are two common frameworks, the one I just said, which is old carts, and then PQRSTU, which is P, provokes, Q, quality, R, region or radiation, S, severity, T, timing, and U, understanding. Then we go into past medical history, which helps us understand the client's overall health trajectory, not just what is happening today, but what has happened over their lifespan. And we're going to begin this by asking medical problems, including acute issues, chronic conditions like diabetes or hypertension, and conditions that have resolved. So it's important to clarify timelines. And then next we want to review childhood illnesses like asthma or rheumatic fever or recurrent infections, because early conditions can influence into adulthood. And we ask about serious accidents and injuries as well as hospitalizations, including approximate dates and reasons. These events can uncover complications or long-term effects. Surgeries are also essential to document. Even procedures from many years ago can have ongoing implications like scar tissue or altered anatomy, anesthesia complications. We're also going to assess their immunization status, which supports primary prevention and provides us insight into their risk factors. For adults, we include screening tests such as mammograms, colonoscopies, pap smears, or lipid panels, and this is going to tie into secondary prevention, which is identifying disease early. We also review obstetric history for females, including gravida, which is the number of pregnancies they've had in the past, para, which is the number of live births. Pregnancy history may reveal complications like gestational diabetes or preeclampsia that increase future health risks. Sometimes clients may not recognize something as medically important, so we may need to gently probe or clarify. And finally, we're encouraging our clients to maintain copies of important medical records, keep an updated medication list. This really supports continuity of care and improves patient safety. Current medications. So when collecting a medication history, nurses are going to go beyond simply just asking what medications you take. We're going to need to gather a complete list, including prescription medications, the name, dose, frequency, route, and reason for use, any over-the-counter medications. Many times clients don't consider these real medications, but they can significantly affect health, like NSAIDs or cold medications. Supplements and alternative products, you want to ask about vitamins, herbal remedies, protein powders, CBD, homeopathic treatments. These can interact with prescription drugs and impact lab values or procedures. So it's essential to assess those, and as well as their adherence. Like, are they taking the medications as prescribed? Do they have any missed or skipped doses? Have they stopped any medications on their own? And if they have non-adherence, you want to explore why. Sometimes it's cost. Sometimes they don't take it anymore because of side effects, forgetfulness, cultural or personal beliefs, limited health literacy. So you want to avoid judgment here, but you want to use open-ended questions. Reconciliation, this is going to be a patient safety priority and a core part of their assessment, going over their current medications with them. Allergies. So when collecting allergy information, we want to go beyond simply asking, do you have any allergies? We want to clarify 3 major components or categories here with medication allergies, antibiotics, opioids, contrast dye, vaccines, etc. Food allergies, contact allergies, maybe they're allergic to latex or adhesive tape. The most important follow-up question is going to be what happens when you're exposed to these, and we must determine the nature and severity of the reaction. So is this like an airway or anaphylactic reaction where you get short of breath or throat swelling? Is this a skin reaction? Do you get rash or hives or itching? Do you have GI symptoms like nausea, vomiting, diarrhea? Or is this a side effect rather than a true allergy? For example, codeine makes them nauseous. This is a side effect versus penicillin causes throat swelling. This is a true allergy. Severity is really going to matter because airway reactions are life-threatening and they require more strict avoidance and clear documentation. So accurate allergy assessment is a major patient safety priority and it prevents serious adverse effects. Family history, this is going to help us identify genetic risk and inherited predispositions. So we focus primarily on first-degree relatives like biological parents, siblings, children. These relatives carry the highest genetic relevance. We also can consider second-degree relatives like grandparents, aunts and uncles, nieces and nephews, half-siblings. Next, we're going to document the age of the onset, and this is going to matter. For example, like hypertension at age 75 has different implications than hypertension at 35, or colon cancer at 42 raises more concern than colon cancer at 80. So early onset suggests stronger genetic risk. What conditions are most important? I want to encourage you to think about inheritable risks such as cardiovascular disease or hypertension, hyperlipidemia, diabetes, stroke, cancer, especially breast, ovarian, colon, prostate cancers, or autoimmune disorders, sometimes mental health disorders or substance use disorders. This information is really going to guide us on screening recommendations, prevention planning, risk stratification, and patient education. Social history. So the social history helps us understand how the patient lives, not just what diagnoses they have. So health outcomes we know are deeply influenced by social, behavioral, and environmental factors. So this is where we assess their determinants of health. So education level, their health literacy and medication understanding, that goes hand in hand here. Occupation or hobbies. Occupations may expose patients to chemicals or repetitive strain, physical injuries, or stress. Hobbies can also increase risk, like contact sports or traveling or hunting. Housing and finances. So these are critical screening questions you want to ask about. Do they have stable housing? Do they have ability to afford their medications? Food security. Exercise and sleep. Exercise habits influence cardiovascular and metabolic risk. Sleep patterns can help reveal sleep apnea or anxiety, depression. Safety. You want to ask about seatbelt use, fall risks, firearms in the home, domestic violence screening. Safety questions here are going to help prevent or protect our patients. Tobacco use. We want to calculate pack years, which is packs per day times years smoked. This is going to help us quantify risk rather than simply documenting that they're a smoker. Alcohol use. We want to use screening tools like audit, and you want to clarify how much, how often. Do you have binge patterns? Other substances. And we want to ask that in a non-judgmental way, because substance use directly impacts medication safety or mental health and chronic disease management. Do they have support systems? Like, who helps them at home? Who can they call? This is going to help strongly predict their recovery and adherence. Stress and coping. Sexuality. You want to assess when appropriate. Are you having any sexual activity? Do you use protection? STI risk, reproductive concerns. Then we have the review of systems, which is a systematic symptom inventory, and its purpose is to identify symptoms the patient may not have mentioned during the chief complaint or history of present illness. So sometimes patients focus only on what feels most urgent, but a review of system really uncovers additional concerns. It can also reveal occult or underlying disease. So this is where our comprehensive versus our focused review of systems comes in. So a comprehensive review of system reviews all major body systems. It's often done during initial full assessments. It's going to help establish a baseline, whereas a focused is going to target systems related to the chief complaint. It's used in follow-ups or problem-focused visits. Like if they're having chest pain, we're going to focus on cardiovascular, respiratory, or GI systems. And you want to do some systematic questioning here based on body system, because review of systems is structured and it's organized, and we move system by system. Choosing appropriate physical assessment techniques is going to kind of be where we're ending this lecture. So let's move to the last section. So we're moving from collecting subjective data to gathering objective data. So the physical exam is performed using 4 primary techniques, which is inspection, palpation, percussion, and auscultation. And these are the building blocks of our head-to-toe assessment. So inspection is always first. It's that careful, deliberate observation. It includes general appearance, skin color, symmetry, movement, behavior, respiratory effort. It happens the moment you walk into the room and look at your patient. It's not just when you begin touching the patient. It requires good lighting and focused attention. Then we have palpation. Palpation involves using your hands to assess temperature, texture, moisture, tenderness, masses, organ size. We start with light palpation, then we proceed to deeper palpation if appropriate. We want to always assess for pain first when we're doing this and watch the patient's facial expressions while palpating. Then we move on to percussion, which involves tapping the body to produce sound. It helps us assess density of underlying structures, air versus fluid versus solid masses. For example, lung sounds produce resonance. A full bladder produces dullness. Hyperinflated lungs produce hyperresonance. We'll get to that, don't worry. Auscultation. Auscultation means listening. Typically with a stethoscope, we listen for heart sounds, lung sounds, bowel sounds, vascular bruise, in abdominal exam, auscultation comes before palpation and percussion because touching the abdomen may alter bowel sounds, but we're going to go over that, don't worry. Safety considerations during assessment. So assessment is not just about collecting data. It must always be performed safely for both the patient and you. So safety starts before you even begin the physical exam with hand hygiene. It's always going to be the first step before touching a patient and after touching a patient. Proper equipment use. Use equipment correctly and safely. You want to clean your stethoscope diaphragm. You want to correct blood pressure cuff size. Proper thermometer technique. Ensure that the equipment is functioning. Patient positioning. This is going to affect both assessment accuracy and patient safety. So, examples would be sitting the patient upright for a lung assessment or supine for abdominal exam. You want to protect dignity. You want to preserve privacy at all times. Close the door or curtains. Drape them appropriately. Expose only the area you're examining and explain what you're doing before touching, and respect and build trust and reduce anxiety here. Monitor for any distress, so watch for any shortness of breath, dizziness, fatigue, pain, anxiety. If the patient is going to become unstable during your assessment, you want to stop, reassess. You never want to override safety like we talked about. Finally, one of the biggest shifts from just doing a skill to being a nurse is knowing what's normal and recognizing when something isn't. So assessment is not just collecting data, it's really, again, interpreting that data. So knowing expected findings. You must, as a student, first master what is normal. You want to know normal lung sounds, normal heart sounds, range of motion, expected age-related changes, because you can't recognize abnormal until you know what normal is, right? Want to recognize any deviations. Abnormal doesn't always mean dramatic. Sometimes it's really subtle, like a slight asymmetry or a small change in mentation, mild crackles or a new rash. You want to always compare it back to baseline. So a patient's blood pressure, again, might be 100/60 and it might be normal for them, or their heart rate is in the 50s and maybe they're an athlete, it's normal for them, but we always want to check that that's their baseline and follow trends. You also want to document accurately. Assessment findings must be objective, specific, measurable. Instead of lung sound bad, which I know you're not going to do, you want to document fine crackles in bilateral lower lobes, because clear documentation is going to support communication, continuity of care, and legal safety. You didn't go through all of this to get a license to lose it. So that is it for our intro to health assessment, and I hope you enjoyed me tripping over my words, but it's okay. I'll do better next time. I will see you in class. I can't wait. I'm excited for this course, and I hope you are too.